I am tasked with emphasizing evidence related to chronic inflammatory bowel diseases and therefore ulcerative colitis, where there is the greatest evidence of efficacy, and Crohn's disease. Ulcerative colitis is a chronic inflammatory disease involving the whole intestine, involving the colon, and as you are well aware, it may have a segmentary localization, in the sense there may be rectal or sigmoid involvement, rectal, sigmoid, and left colon involvement, or possibly the colon is affected completely, which in this case is called pancolitis. Obviously, the greater the extent of disease, greater the probability that the patient has clinical symptoms that compromise the quality of life and obviously jeopardize health, and therefore is a greater risk of repeated episodes and a need for surgery, for colectomy. In terms of evidence on the use of GMA in this context, there is plenty, and I tried to identify it. I will show you the most important. The first papers were published at the beginning of the 2000s. This is a comparison study with prednisolone in patients with disease, ulcerative colitis, corticosteroid dependent. A large number of patients because, as you can see, there are 69 patients with ulcerative ulcerative colitis who have been treated in a randomized manner with prednisolone 30 mg per day or granulocyte monocyte apheresis using an approach of 1 cycle per week or 2 cycles per week, according to the severity of the moderate to severe disease. As you can see, the 12-week outcome data were in favor of using GMA versus using cortisone. There was no statistically significant difference for clinical remission, while there was a statistically significant difference, obviously in relation to the use of the cumulative dose. Here, therefore, the use of GMA was essentially recommended in the conclusions of this study as an add-on to standard medical therapy for the containment and the treatment of the disease. Another randomized and controlled trial by Dr. Bresci's team, which of course included Dr. Sacco, who introduced this seminar, was conducted in Pisa. It was a randomized study that again compared GMA versus corticosteroid therapy. In this case, we will discuss a pilot study, therefore with a sample size limited to 40 subjects. The patients received 5 cycles of GMA, and clinical response was defined by a value below 6 with regard to the follow-up that was made 4 to 6 weeks from the start of therapy. As you can see, essentially, the complete clinical response was 70% versus 60%, a partial response of 20% and 15%, and also all other parameters, let's say, comparing the 2 types of treatment, were overlapping. This shows that essentially GMA, in this cohort of patients with moderate to severe disease, acts in a similar way to corticosteroid therapy that we know is currently a more effective therapy for the control of chronic inflammatory bowel diseases, although it is burdened by all the side effects which limit its use repeated over time or chronically. Another very important study instead came from Japan and was published in DIG, Liver Dis, in 2008. It compared intensive GMA, in which essentially they proceeded with 2 cycles per week for the first 3 weeks, and then 1 cycle per week in the 11 sessions that followed. And this type of therapeutic approach was compared with intravenous prednisolone, 40 to 60 milligrams daily for 5 to 10 days. See how the response rates, remission rates for GMA versus intravenous prednisolone were essentially comparable to each other. Of course, GMA was slower in inducing a sustained clinical response, but then, over time, it proved to be more effective in maintaining the remission rate. Because of the evidence in these data, of the importance of these data, a randomized double-blind sham-controlled multi-center study was conducted. The first name is Bruce Sands, published in Gastroenterology 2008. In this trial, 168 subjects were enrolled with moderate to severe active disease. Efficacy and safety were evaluated at 12 weeks. 10 apheresis sessions were performed over a period of 9 weeks. In this case, the clinical data compared with sham was slightly higher compared to adacolum. That is, in favor of adacolum compared, obviously, to the sham treatment, but with no statistically significant difference. However, it has been underlined several times that this study was criticized quite severely with regard to the inclusion criteria in terms of the analyses performed at a later stage, so much that a post hoc analysis was published in Digestion, which analyzed the effectiveness of GMA in patients who had neutrophil activity at endoscopic and histological level and greater inflammatory type activity. The data are obviously found to be in favor of granulocyte monocyte apheresis compared to the sham control treatment. This supports that if there is inflammation, as the doctor said very clearly earlier, if there is inflammation, if the activity of the disease is of the inflammatory type, the probability of having a positive clinical response with this therapeutic approach is definitely higher. In Japan, this is their registry, which essentially evaluated where there is the greatest number of case histories of patients treated with this method, 697 subjects with regard to safety data, 656 with regard to efficacy data. The recorded response was 77.3%. 17.1% patients were substantially unchanged, and 5.6% of patients had worsened. Visible on the right of the slide are the histograms, which show you exactly how the therapeutic efficacy in this study, in this Japanese population registry, was in favor of treatment. If we view the number of sessions to achieve this kind of response, see less than 5, greater than 6, the response in percentage terms was 81.2 if greater than 6, 71.5 if less than 5, therefore in favor of the use of multiple sessions of granulocyte monocyte apheresis to obtain the expected result. The Spanish study was also a registry study, substantially overlapping, maybe a little less effective compared to the Japanese one. Here we talk about 60%, there we spoke about 70%, but in any case confirming the Japanese data. We too have published a small study in terms of our patients treated here in Padova, 41 patients who have had GMA and in whom the clinical response was evaluated. It was evaluated with a 6-month follow-up. You see that in patients with mild activity, with patients with moderate to severe activity, definitely the best answer that we got was in patients who had a mild activity, corticosteroid dependent, obviously, or intolerant, so needing an alternative therapy to corticosteroids. With regard to cumulative data, this is a meta-analysis published in Digest DISCOG in 2010, where you see it is in favor of the use of apheresis versus the control treatment and remission at 6 weeks and remission at 12 weeks. There are few things to say also in relation to safety and efficacy. These data, in part, can be obtained from registries. In part, they can be obtained from this study published in JCC by Dignas, which was a single-arm, open-label, multi-center trial. 86 patients enrolled with history of insufficient response or intolerance to immunosuppressants and biologics, almost all with moderate disease, pancreatitis, and 42.4% patients intolerant to or not responding to anti-TNF. These are data on clinical remission and clinical response. You can see more or less 40% of clinical remission, 55% clinical response at 5 and 12 weeks, data that was substantially spread, in terms of patients in whom immunosuppressants failed, anti-TNF failed, or both treatments failed. Similar data were then published by the same author in the Scandinavian Journal of Gastroenterology, addressing and analyzing also the populations with steroid-free remission and steroid-free response, visualizing, substantially showing that 25% to 30% of patients succeeded in not requiring corticosteroids. Also, in the most recent Japanese registry, where currently 920 subjects have been included, you see the efficacy data, both as regards the Mayo score and the clinical score, are extremely good and confirm the validity of this method in clinical practice. The safety data are also certainly good. The only thing from this registry, it has been underlined that perhaps the less responsive population is the elderly or the one with an excessively severe endoscopic activity. So the authors suggested focusing more on patients with mild or moderate disease, or in any case on those intolerant to standard therapies. With regard to Crohn's disease, which differs from ulcerative colitis, there is a little less scientific evidence in literature. But there is the study, definitely major, one of the most important, published by Dr. Sacco in JCC, on 118 treated patients with remission data after 5 weeks to 6 months, 12 months, and then over time definitely positive, 40% to 50% of subjects responding to therapy with 5 weeks of treatment, 1 cycle per week. On the other hand, the data from the Japanese open-label randomized study of intensive treatment, 2 cycles per week versus 1 cycle per week, in Crohn's disease essentially says that there is a better response to intensive therapy compared to the standard, and that probably, as we have seen also in ulcerative colitis, surely if we do not limit therapy to 5 cycles, maybe we can obtain an improvement in the treatment. With regard to the Italian apheresis registry, this is data published by Passalacqua at 3 months, a positive outcome as regards IBD, specifically Crohn's disease. 36 subjects were seen in 61.3% of subjects. Data was recorded also with regard to safety, with no significant adverse events recorded. Also for Crohn's disease and ulcerative colitis, there is data from a randomized controlled sham study in 157 subjects, also an American study, Bruce Sands is the first author again, published in Gut. In this case, the outcome data did not show GMA was better versus sham trial. However, in a post-hoc analysis, which analyzed the patients who had previously undergone treatment with anti-TNF or had concurrent 5-ASA or had more marked inflammatory activity with a CDAI greater than 13, GMA was in any case better compared to sham in the treatment of Crohn's disease. Finally, I would like to speak about safety data, which was also collected for Crohn's disease patients, also in patients with Crohn's disease. Essentially, no particular problems were recorded. The meta-analysis, always published in Digest Dis-Sci, with regard to treatment with GMA in Crohn's disease patients, supports apheresis versus the control group. I will end by saying that the GMA, based on efficacy data, present in the literature, is effective above all in patients with ulcerative ulcerative colitis, reduces steroid use, reduces the probability to have a recurrence of disease. It is useful when conventional therapies are ineffective or contraindicated, and is particularly effective when at histological level it is possible to document an excess of neutrophils in the biopsies, but this is quite intuitive based on the mechanism described earlier. Greater effectiveness can be recorded in patients who are steroid dependent or refractory with mild to moderate disease and seems effective in patients with Crohn's disease, even if a little more caution is required here because evidence is more limited. I presented to you a lot of data on ulcerative colitis, limited data for Crohn's disease, but certainly patients with Crohn's disease, with colonic disease, and with inflammatory behavior are more likely to respond to GMA therapy. Thank you for your attention.